Thank you for the introduction. What I'm going to do is a whistle-stop talk. But to start, do you watch Strictly Come Dancing?
Yeah.
The head judge, where's she from? Shirley Ballas. Finally put my town on the map. She's from Wallasey. Does anyone know where Wallasey is? Anyone from Liverpool here? Yeah, we're on the Riviera side of the Mersey. Big river, keep the Scousers out. So I'm a Scouser as well, I'm an adopted Scouser. But I'm from Wallasey, and it probably what qualifies a GP from Wallasey to talk at Somerset's local medical committee. Well, as Chairman said, part of it is to talk as President of the NAPC about the primary care home, but to put it into context with the clinical thinking that has gone into the construct. Before I start, I also want to introduce a colleague who's here, because as you're probably aware, NAPC have an agreement through a contract with NHS England to support Somerset in the development for those who wish to develop this style of delivery. And Andy Mullins, Andy, take a bow as well, who's here with us from the NAPC, who's our man in the southwest who may help with the questions later on, I hope. So what I thought I'd do with this is put into context, not the detail or some of the development of the primary care home, but where it came from, because colleagues are still asking questions. Why have we gone to 30 to 50,000 population sizes? What is the evidence behind the construct of the primary care home? So I wanted to try and put that into context. And I'm quite excited about this talk. I rarely, for those of you who've seen me present before, I don't like using PowerPoint. Never worked with PowerPoint children or animals because something goes wrong. But the team centrally say you've got to use it. So I'm quite excited about this presentation because I've not seen it myself before. So just to put in the background where we are and how the primary care home as a term, not important, but as a construct and a concept important. We know we're coming to the end of the 5-year forward view. It finishes in October 19, but by the time we get to there, we'll have the long-term plan. We're not sure it's a long-term plan or a 10-year plan. Interestingly, I was hearing Chairman saying about the future and whose future is it. I've been saying on the long-term plan, maybe anyone over 55 should only be there in an advisory. We should have this populated by people who are going to be delivering the 10-year or the long-term plan. But I wanted to focus first of all on the organisational memory and the evidence that we've built in to the construct of the primary care home, because it has been in gestation for about 25 years. The two things we're finding as we're discussing the principles of what makes the primary care home work is that colleagues say, well, there's not a lot new in what you've said, James. And that's exactly it. We're not doing new invention, but we are building in an organisational memory and trying to remember what works and not try harder at what has failed. So we've looked at something that this piece of work I first did for Andy Burnham when he was the Secretary of State for Health and I was at the Department of Health. He asked me to review why reforms had failed in the past and how could we build in something that was sustainable. And there were 3 recurring features, and that has still persisted despite the there's always the political cycle, but there's 3 recurring features that we need to make any reform sustainable. And the change of culture. We always talk about a bottom-up approach. It's about the service developing under a bigger system. We are hearing from the developments to date, which I'll talk about later, that the reason why colleagues across the clinical and social care community are saying they like it is because they own the agenda, they're given the tools to do the job, but generally the development is by the teams that are doing the work. And the cultural persistence of central control and telling people what to do is a reason why reforms often fail. I've got a slight concern about having a mandate to say everyone's got to work in a primary care network, but there is a reason behind that. Leadership as well, we always try and create the next positional leader. If it's not a manager, then it's a clinician, and somehow that positional leader will change the system. we've seen that that doesn't generally work. We need that senior leadership to steward, to help with strategy, but the leadership that's really important is the day-to-day clinical practice, the style of practice that the teams that are doing the work lead their practice in a different way, and finally have the tools to do the job. We always talk about data, the information that allows the teams that do the job to make the best use of resources and how best to deploy the people and the service. So they're the three things: the cultural change, the leadership as a style of practice, and the tools that help you do the job are things that we're building into the construct of the primary care home. I heard the word already. We talk about transformation incessantly, as if we're going to transform something. Even a 5-year plan is too short to do transformation. When we first discussed the concept of the current iteration of the primary care home with Simon Stevens some 3 years ago, we did point out that the programme would probably be at least for 10 years, because transformation is a series of experiments, some of which will go wrong. The programme will have enthusiasts who get a bit disenfranchised, may have to reset, to recalibrate. But it's the sequential arrangements and the incremental process that's important. Now, 10 years is a sort of approximate, but it's trying to put into context that transformation takes a long time. It's not one moment you have a robot and next minute you transform into a car. It's about the process by which you start, we're all on journeys, aren't we now, but a horizon that you're moving towards, and accepting that you don't get it right first time, and there's no perfect arrangement to start it, so there's no ideal circumstances. Everyone's waiting to have the right environment. There's always going to be tensions, there's always going to be financial difficulties, there's always going to be hurdles to get over, and it's got to be recognised how they're managed in this transformation process. On this slide, probably the most important line is what we've got to get right, and one of the things we are measuring in the quadruple aim of healthcare. You've heard about the triple aim and the quadruple aim. The quadruple aim came from the recognition. The Institute of Healthcare Improvement in Boston came up with a triple aim some 10 years ago, that any healthcare system development needs to have built into it the experience of people receiving the care, patient satisfaction experience, population health management, and driving down per capita costs, getting better value-based care. But what UK added to it was the fourth element, which is about the experience of delivering care. Because one of the things that, and I'd say the biggest financial risk we have in the NHS at the moment, is the morale of the staff. And we are seeing too many colleagues who are leaving the service early, getting overstressed. We're trying to build something in that changes the experience of delivering the care. So staff morale is really important to this, and that's what we are measuring within the primary care home. Does it make the people doing the work feel as though it's not going to be a lot easier, but is it changing things like work-life balance, professional esteem? I'm a bit loath to say the Americanism, the joy of practice. It's not about joy, but the bit at the end of the day where it says, this has been tough, but I'm ready to go again tomorrow, as opposed to, sadly, some colleagues saying, I hear what you're saying, James, you've just come a bit late because it's 1 year, 3 months, 2 days and 4 minutes to my retirement. And sadly, we've seen some colleagues who are staying professional, but are counting down the time. What we're hoping to do is change some of the mindset where colleagues are going, you know what, this is what I'm going to stay and do for a while longer. And probably the other thing is that's really important into our construct is this about workforce design. Sometimes we always look at the workforce in terms of numbers. Have we got enough of each species? Have we got enough GPs? As opposed to, if we're redesigning the work and analysing the need of a local population, then the workforce construct may be very different to what we've got in general practice at the moment. All making sense. But I want to labour this to a point just to make sure that there's an understanding that we've not just come up with an idea as a best guess at 30 to 50,000. There is a real reason why we've got the construct of the primary care home. And again, we're building in this, I won't read through it, but about the elements that makes reform sustainable and successful. And what we're hoping to do with the support of the NAPC and experts like Andy Mullins is that we'll help with the skilled project management operationalise what I'm giving the headlines for. So again, I'm happy to leave these slides, but these are again some of the elements that we've built in. So where are we at? 3 years after the launch of the primary care home, this was something that was built into the 5-year forward view. It was personally commissioned by Simon Stevens. Nav Charna, who's the former chair of the NAPC, and myself were with him in 2015, where the NAPC were discussing with NHS England about how we could help, and he came up with a line, put up or shut up, bring me something that will engage the wider clinical community in delivering the aspirations of the 5-year forward view. So the construct of the primary care home ultimately is to deliver an extended range of services in the community, which reduces the necessity of hospital beds, facilitates shorter stays in hospital, facilitates discharge, prevents admissions, ultimately, but at the start we're just going to get the environment right. Primary care networks is the overarching term now that's been agreed with NHS England, which is saying this is the principle. The primary care home is the leading example of the network programme predicated on the principles and the size of population served by a primary care home. But it doesn't matter whether the name is a neighbourhood, a locality. We've even heard some saying primary care home networks. But it's the principles of delivery which has got this strong evidence base, or as strong an evidence base as we can build into a reform programme, and an organisational memory, say, that goes back to at least the creation of the internal market. Not recreating any former reform, but unashamedly saying what was it about total purchasing and fund holding that changed behaviours? What was it about practice-based commissioning that got the locality movements, and from commissioning to groups of clinicians saying, well, it's about improving provision. GP federations were created by GPs who said, well, practice-based commissioning, what it's really about is about how we deliver the service more efficiently. The collegiate aspects of PCGs before we got PCT. So we're trying to build that memory in, so hence the networks are using lots of terms for delivery. We're calling it the primary care home. It's not the greatest name, but we're saying it's the home of improved management of the registered population, because it is built on the combined registered lists of the constituent general practices. It's the home of the team that does the work, because we are moving to a one-team approach for the delivery of the care for that registered population. And it's the home of the data, the information which people say is where their care record is kept, building on the GP record to expand to import the information that's held in community services, in mental health services, and in the local authority. So these are the terms we're saying. NHS England, when we first discussed with them, they came up with a term, new care model style primary care programme. So we said, let's just call it the primary care home. Nothing special about it, even though some still say, is it a care home? It's the home for better data management, the better management of the population, and the home for the team that does the work. I say we are looking to ultimately, over this 10-year programme, have a one system approach, not necessarily one formal organisation, but some glue within the constituents who are delivering the care to this defined population. So finally, on this journey to getting to the document that Simon Stevens said, okay, we're going to make this not into one of the Vanguard programmes, but it will be part of the 5-year forward view delivery, and that's where NAPC got a contract to deliver the first programme of individual sites, which I'll come to, but now we're moving into areas where an STP footprint, and Somerset's an example, saying we think this is a model that would be right for our particular health community. So it's looking at transforming, in the sense of a long period of time, first contact care. We know that 80% of first contact care is currently with general practice, 90% is in a community setting, so it's based in the community, but turning that first contact care into more finished episodes rather than lots of transactional or referrals, so that the team that does the work with the diagnostics and the ability to extend care. The complete care community is saying that teams that is doing the work has got to be based on the need of that local population. And as we know now that, and certainly the 30 years I've been in practice, the needs of the people registered with my practice in Wallasey have changed quite dramatically. Sometimes now in surgery, I think the wellness agenda and what makes people function is, have they got a home, have they got a job, have they got a friend? If they've got those three, they're pretty well. And if they've got those three, they can deal with other illness or ill health that befalls them in a better way. But I haven't got a prescription for the wider determinants or the social determinants of health. So we've got to build that into the construct, because some of what we're hearing from general practice is they're overloaded with a whole range of need that doesn't necessarily fit with the training of the community physician or the general practice team. So building in a workforce that reflects the need of the local population. And finally, if we are getting in the mature stage to, and we're seeing in some areas, indicative budgetary devolvement to primary care home sites, where they can have a voice in what we're talking about, stewarding the resources. Not hard budgets back in practice, but the ability for the teams that are doing to work to say, how do we best deploy our community nursing service? How do we best manage some of the resource that we are committing, whether we're conscious of it or not? Whether it's a case of we closed our doors at 6:30, or whether we're making referrals, can we take some control of the resources or the consequences of the resource utilisation? So the primary care home ultimately then had four, as we've built that in, we've got the four characteristics. It's changing from the care that I think I've delivered quite well in the, actually I was just going to say that, how you qualify yourself. Often you talk, I've been a GP for 30 years. Well, what have I done in those 30 years? I've redefined myself. I'm a GP of 250,000 consultations, I think, to date. But what have I done in those consultations? I think for much of the time, despite doing the screening programs and trying to do detection, and now our Secretary of State is saying prevention is better than cure, I've generally, for those people who have chosen to register with my practice in Wallasey, waited for them to get ill and then treated them. And I've tried to do the best job I can with the resources that I've got. But how can we start to do the analytics that looks at the real need of the population and the wider determinants, and particularly the social determinants of care need that presents to the general practice anyway? We don't want to make the primary care home GP centric, but we are saying that the population served is based on the amalgamation or the association of the combined registered list of the constituent practices. So if we're saying that you access the NHS through registration, it's got to have GPs accepting that they are going to work together in a collective, maybe still as sovereign practices with their own contracts. Some are saying, well, no, we might think about in the future doing some merger, but it doesn't matter, whatever the constituents think is right for them. But building a population where you can do the analytics that make some sense, so that where you've got some rarities, or you've got a need that isn't being met because of it's not recognised in a population of 5,000 or 6,000 patients that I have in Wallasey. How do we scale it up to do the analytics and the better management, the proactive management of care for that population? Once we know that need, how do we deliver the right team, building from the general practice but incorporating the other primary care contractor services? We've started with pharmacists in general practice. I'm not sure whether that's the long-term future. How do we utilise the community pharmacy, the community sensory services, optometry and hearing services, and dental services, and we're having some success, and we have published some documents about how that's happened without moving the dentist into a different environment, or the pharmacist. How do we start to collectively work the good old aligning incentive so those 4 contractors work in a collaborative rather than a competitive way? How do we build in then the need that is growing in mental health, the community services? How do we make sure that we have some secondary care consultant oversight built into it, and particularly social care, and now even local authority care? Some sites are working with the probation service because they've been looking at, in Wirralby, we've been looking at adult ADHD. 40% of males at Her Majesty's pleasure in prisons are in there because they've got ADHD. And we're talking about the reintegration into society of offenders. Well, if they're coming out with undiagnosed ADHD, it's going to be very difficult for a healthcare system to manage that particular problem. So we've got to build in some alliance with the probation service and the police service. Just as an example, we've been talking with the fire and rescue service. A fire officer some 2 to 3 years ago, when we were talking about the principals, was saying that they are doing dementia care, home visiting, they're doing falls prevention, they're doing alcohol withdrawal service, they're doing smoking cessation. And I came up with a line to ask the fire officer, why? Why are you doing that? Which was, he smiled because he thought, falling into the trap. He said, you've just been talking, Dr. Kings, about prevention. The people, that what we're doing, those people set fires to their homes, and we want to prevent it. So if they come in drunk and they're smoking, or they're having falls, or they've got early dementia and they're leaving the gas on, we're finding an ever-increasing number of people who are setting fires to their homes. We want to do prevention, and we're already doing that. So how do we knit that in? Now that's going a ways down, but it's the principles of the community assets that are starting to work in this construct of the primary care homes. But starting from the primary care contractors, the social, community services, the mental health services, then social services, in an incremental way. The third is the alignment of clinical and financial drivers. What that means is some responsibility of those teams then to steward the resources, to make the decisions, or certainly have an early voice in the decisions about how services are deployed. One thing came to mind 3 years ago when this time of year one of my patients needed a B12 injection, a flu jab and a blood count, and 3 different people had to go because the district nurse couldn't do the flu injection, the flu had to be done by the practice nurse, and a healthcare assistant from the community trust had the contract to do phlebotomy. It may not happen here, and it's been changed. But if those 3 people were designing the service, they would not have started that good old line, if I was designing, I wouldn't have started from this position. So give the ownership to those 3 people. They'll go, well, we'll talk about the contracts later, but let's discuss who's the most appropriate just to go once and get it right first time. Simple example, but it's the principle of the people who are delivering the work deciding how to use the resource. And then finally, the 30 to 50,000 magic number. Is it a magic number? Does anyone know where the 30 to 50,000 came from? You've probably heard, if you've heard me before, you'll know. What's it about? Is it? Seems like a good idea at the time, because my time in reforms and the two 4-year stints I've done at the Department of Health, we've always talked about does size matter? Should a CCG have 100,000 or 200,000? Should a health authority? Should a practice-based commissioning group? Does anyone know the 30 to 50,000? Because it's out there, isn't it? Primary Care Network's 30 to 50,000.
About teams. It's
Absolutely.
The size of the team that supports that. They get to know each other well and can then function as a team most optimally.
There we go. Perfect. It's the workforce. It's all about the workforce. Because if you're doing population health management, and we can do that, but if you're saying the principles of population health management, you can do that on far larger populations and possibly have some analytics that work better on larger populations. If you want personalised care, then we know that some of, even now, the best responses from people who are saying that personalised care is best when I'm working, if I'm registered with a single-handed general practice. Single-handed general practice still gets really high satisfaction from patients. So personalised care and teams may work in smaller groupings far better than larger groupings. If you want to risk manage budgets, then you want to do that on huge scale. But if you want to get a cohesive team that can do all of it, what we did was look and mapped, we used 5 CCG areas and mapped what would be an optimal size based on a workforce that can work as one team and risk manage a budget. I won't go into the detail of that, but mapping that back, we know that you need somewhere between 100 and 200 people working together to be able to have whole-time equivalents and deliver the extended care that we're describing within the primary care home. We know there's not a lot of evidence in health, but from researching why the military have terms like squads and teams and platoons and brigades are all predicated on the right size of team to do the work that's required of those teams. If you look in industry, there's lots of evidence about the productivity related to the size of workforce. Social media, social anthropology, one of the things that often people quote is the Dunbar number, which isn't a number. Have you heard of Robin Dunbar? He's a social anthropologist from Oxford who first started to talk about, in ape studies, the cognitive level at which we can work together in social groups before we start falling out. And going right the way back to military, the Roman Empire knew that the centurion, how many men did a centurion look after?
100.
No, he didn't actually.
80.
It was, when they were junior, they could manage about 80. When they were senior, never got more than 120. But they knew that fighting unit could work together with people who interacted on a regular basis, and when the blood started to flow, would look after each other. When they got bigger than that, when the blood started to flow, they'd run for cover. And they were able to take over the world by taking on much bigger fighting forces. These are just examples. So, Facebook, all on Facebook? Or I guess a lot. We don't admit to it, but has anyone got more than 100 people on Facebook? Because if you have, Facebook say they're not your mates, because you don't interact with them on an annual basis, and one of the definitions of friends is about the interaction on a regular basis. They're saying that would be about a year. So there's lots of information, not a lot in health, about the cognitive level at which teams can work efficiently, that can manage resources, that can at least meet on a regular basis, know each other's skills and competencies, know each other's names, know a bit about each other, so that when something's going wrong, they can pull together rather than say it's not my fault or it's not my problem. And it's somewhere between 100 and 200. And if you map the workload and the resource utilisation of about 100 people predicated on a GP model with expanding out to deliver whole population management, you can look after about 30,000 people based on workload statistics. If you've got 200 people, you can work on about 50,000. So he's saying that if you're going to use the principles of the primary care home, it's the right place to start on this 10-year programme. It may not be the right place to finish. We don't know. Over time, it may be that you can work in slightly larger populations, which is probably the preference of NHS England at the moment, as opposed to the clinical teams are saying, oh, it's a bit big, we'd like to work in a bit smaller. But if we are going to get some budgetary control, then the risks of working in smaller units gets greater. Laboured that, but that diagram on the right-hand side was an upgrade of a diagram I drew in 1992 about something that I was doing with the Office for Public Management a long time ago as a young GP, about how we could change the delivery of care, rather than everything being filtered through the general practitioner portal, having the right team to manage care which could extend and then keep people out of hospital. But so they're the principles. I'm sorry to labour them, but it's really, really important, because even if you're doing primary care networks, the only reason you would do it in the 30, 50,000 population is the design of the workforce linking back to the population health need. Are we okay? Are we about done?
How long do you want?
2 minutes? Okay, just to say where we're at the moment is that from an idea to a spread which hasn't had much resource other than NAPC's support. We had 15 rapid test sites that had a bit of money to get some headroom. We know now there's some resources coming through primary care networks, but by understanding the concept, that it being driven by the teams that do the work and taking ownership, we've gone from a concept to a 9 million population coverage within 3 years, or less than 3 years. And that's not been by persuasion. I am not here to sell anything. I'm here to just give the evidence, the experience, and where there's energy and people saying this is right for our local community, we can help based on that experience. The thing that's changed is that when we met for the next round of contracting for NAPC working within NHS England's arena, it was Simon Stevens said that we need to go from Jackson Pollock to Mondrian. I had to look that one up. Jackson Pollock, sort of the splashes of colour over the country, as opposed to Mondrian, which is more collective colours. So he was saying, can we now consolidate some of that development on an STP or an ICS footprint? We're working with 3 ICSs over the last year or so in Dorset, in BMLK and in Surrey Heartlands. We've now been challenged to find another 12 areas where there's the energy, the interest to have the support of NAPC, where local teams want to develop the model. We're here to help, and Somerset is one of those areas. Probably, I won't go into the valuation, but we've had external evaluations as well to say, you know, is the policy and the ideals actually working? 2 early evaluations did show, we used metrics in the first year of patient experience, and that was particularly satisfaction of what they were getting and access, and the experience of the people delivering the care. And I picked these out. These were fairly early, but they were really powerful statements, because I never thought that a practice manager and the management, I could say, we can probably talk in the Q&A, would say, you know, this policy made me feel young. Never built that into a policy before. Clinicians who were saying, I'm returning to practice or deferring my retirement. And this wasn't tongue-in-cheek, but probably most powerfully, the chair of a national patient organisation who was helping us do some of the early analysis said, without tongue-in-cheek, I've lived in the same house for 50 years. If I don't get one of these near me, I'm moving home. Were powerful statements, but we built that into a much greater analysis, which was consistent, that was saying something is happening where people who are receiving a service saying, I seem to be getting better access, I'm getting more services when I first have a contact with this new collaborative, and people in the service going, I am enjoying my work more. It's still tough, I still need headroom, I still need some resources to build on it, but it's what I've always wanted to do. And when colleagues say it's what I've always wanted to do, doesn't need to be sold. Chairman, at that point, I'll happy to take questions, and hopefully that's made some sense. Thank you.